To lead us through the first part of our presentation this morning, we are incredibly fortunate to have the Psychiatric Medical Director from Old Town Recovery Center, John Bischoff from Central City Concern. He is a fantastic guy, and we are very, very fortunate to have him with us here today. Please give a warm welcome to John Bischoff. Thank you.
Well, thank you, Paul. I hope I can muster that much enthusiasm for what is actually a really serious topic. But so yeah, I'm John Bischoff. I'm a psychiatrist, practicing psychiatrist. I do 20 hours a week of direct clinical care at Old Town Recovery Center, and I'm the psychiatric medical director. So yeah, I have a career in public psychiatry, mostly behind me at this point. And I trained at OHSU, just to give you some details. I've worked all throughout the public system in Oregon. And I do want to tell you too, just to establish my credentials with you, that nurses are my favorite people. I hope you believe me. And I'll tell you why you should believe me, because earlier this morning I called my ex-sister-in-law, who is like a sister to me. And when I was 6 years old, she was preparing to go to nursing school. And I looked at her nursing textbooks with just wide-eyed wonder. And it was the beginning of my interest in life sciences and in medical science. And so I called her this morning to tell her I was going to be talking to, is everyone a nurse? Right? Everyone, yeah. So I was going to be talking to a group of nurses. She was really pleased, and we caught up, and it was wonderful. So. Yeah, and actually my first physician mentor when I was 16 years old, a friend of mine, her mother was an ER physician. And she invited me to spend the summer at night. She did night shifts, right, so she could take care of her family during the day, with her in the emergency room. The first night I showed up, she said, "I bet you're really excited." I said, "I am." And she said, "Yeah, I bet you think it's going to be you and me and doctor stuff all summer." And I said, "Yes." And she said, "No. You're going to follow the nurses, you're going to work for the nurses, and you're going to learn that if and when you become a physician, the most important person in your professional life will be a nurse or nurses." And she was right, obviously, right? So, and I really put that into practice. I teach the students who I work with and the residents who I work with that is a really important aspect of being a successful healthcare provider in general. So. Anyway, I'm glad you're here. I'm glad you're interested in learning more about depression today. And we're going to get rolling. I want you to know, and this is a part of the take-home, right? Depression is incredibly common. Paul already shared with you how common it is. The numbers are pretty staggering. Actually, in the US and also internationally, it's really a heavy disease burden in terms of human suffering, human lives, and financial costs. And you, as a primary care nurse, most everybody's primary care nurse, is that right? You're in a unique position to screen for it, to identify it, and to refer people for help. Maybe you've already done that. And I love this quote that I think Paul came up with, or someone came up with, right? Save one life, you're a hero. Save 100 lives, you're a nurse. And that's why we do what we do, right? So yeah, we're going to start out with just a brief review of Psychiatry 101, I call it. And by the way, I thought it was interesting that psychology in the little sort of schematic about what we're going to talk about today got left in there, Psychology 101. Frequently confused. In fact, you know what? Before I did my psychiatry rotation as a medical student, I had no idea what a psychiatrist was. I would have confused the two as well. So it's pretty common. Does anybody know the difference between a psychologist and a psychiatrist? Yeah?
Psychiatrist is a medical doctor.
Right, psychiatrists are physicians.
Psychologists have a PhD.
Psychologists have a PhD, right, yeah. We work together really collaboratively in great ways. And psychologists have really great skill to bring to testing, help with diagnostic clarification, with sort of really stratification of cognitive impairment. And also they tend to get better education in terms of clinical therapies. But yeah, psychiatrists prescribe medications. They collaborate with primary care and other medical specialties on the whole care of a person. So, severe mental illness or serious mental illness, the two terms are used interchangeably. We used to say severe and persistent mental illness. We don't say persistent anymore. And before that, actually, we said chronic mental illness. Who remembers CMI? Anybody remember that? Yeah. So we don't say chronic or persistent anymore because the fact is people can and do recover from very severe mental illness, including schizophrenia. We have treatment technologies today that allow us to say that with confidence and to back it up with data. So the formal definition is that it's of sufficient duration to meet DSM-5 criteria. It results in serious functional impairment or which interferes with a person's major life activities. You'll also see in the disorder definition that it includes clinically significant distress. That's the formal. In practice, the severe mental illness that we deal with, by definition, everyone by contract at the Old Town Recovery Center has severe mental illness. These are the major diagnoses that we deal with: schizophrenia, bipolar disorder, major depression, post-traumatic stress disorder, trauma, incredibly common, right, in public sector folks who we serve. Generalized anxiety, obsessive compulsive disorder, among others, but those are the major the major diagnoses. So it's all about integrated treatment these days, right? Does everyone know that? Health reform, it's all about integrated. We've been working in mental health, behavioral health, at integrating with substance use disorders for a very long time, trying to knit together, right? And what's the reason why they're separate? Anybody know why? Insurance, money, right. The pots of money are separate still, actually, although that's about to change here in Multnomah County. So anyhow, we also recognize that people with severe behavioral health problems, and that includes mental health and substance use disorders and/or, right, usually have a big history of trauma. So I know that you all have heard about the ACEs study. Everyone know about it? Been to the website, read about it? Fascinating study. Showed a direct linear correlation between chronic health problems and the number of adverse childhood experiences you endorse, right? And when I say you, I mean us. It was a study done by Kaiser on people just like you and me, right? It wasn't even on the population that we serve in public health, right? So also substance use, obviously, we integrate recovery, and we have broadened the term recovery to include not just substance use disorders, but behavioral health disorders generally, and also integrated physical health, right? I have the great good fortune of, for the last almost 3 years, working at Central City Concern, Old Town Recovery Center, co-located with really one of the finest primary care services in the country. It was recognized as one of 30 exemplary primary care services, the Old Town Clinic. And some of the folks who work there are here today. So it's all about integration, but when I first arrived there, they had moved in together. How long had it been? Maybe about a year or so. So the primary care clinic with the behavioral health clinic, they moved in together before I got there. And there was this integration cloud kind of hanging over the clinic. And especially the leadership that I was interacting with, they were like, how can we integrate? How can we integrate? I said, well, first off, let's stop talking about it, right? Because it puts this burden on people. And secondly, when we start talking about it again, let's emphasize that it's a goal. Integration is a goal. You don't just magically integrate, especially even if you move in together in the same building, right? So we had to recognize the formal ways in which we were coordinating at Old Town Clinic and the primary care and the specialty behavioral health. We actually respond each to the other for emergencies, right? That's a formal way. We have a written policy and procedure that tells us how to do that. So and then we have lots of informal collaboration, right? We just pick up the phone, or what I love is I can just walk down the hall and go talk to my colleagues, right? And sometimes I probably bug them too much, but it's really amazing. And integration is a goal. So I want to say a word about stigma, because stigma, although it's getting better, the stigmatization of people with severe mental health and or substance use disorders persists, right? It's public. There are still stigmatizing images in the media, right? In movies, although that's changing. I'm glad to say that not every mental health professional, not every psychiatrist that you see in a movie is a cannibal anymore. Not every person with severe mental illness is a deranged killer, right? They actually, about how long ago was it? We depicted a Nobel Prize winning economist, right? A beautiful mind. So, but it's also personal, right? We take these images that we see and we internalize them. And if we have severe mental illness, actually it becomes sort of a self-stigmatization, right? And actually, I should admit that even though I've been a practicing psychiatrist, right, for 20 plus years, I still have moments where I have these kind of thoughts, these attitudes and behaviors, right? So what do we do? Because it's damaging to people, right? It limits access to services, health services, behavioral health services. It limits access to housing. Sometimes people are discriminated against based on it, right? And increasingly in this country, where are the mentally ill treated? The behaviorally disturbed people treated? In jails and prisons, right? The criminalization of the mentally ill is a known phenomenon, is well documented now, right? And we could talk probably all the rest of the day about that, but we won't. It's damaging. The good news is it's changeable, right? There's a really excellent research consortium led by this fellow CareOregon in Chicago. They do nothing but research stigmatization of mentally ill people and how to change it. And their fundamental sort of findings more than a decade ago now were that protest, which I kind of just did a little bit, you heard me sort of say, these stigmatizing images in the media, you know, and actually, frankly, I've called CNN before and said, hey, wait a minute, you know, this person used the term crazy to describe a person with a mental illness. It helps, but there's this big, big risk that you're going to get rebound. People are going to say, you know, they threw this in my face, and those mentally ill people, or those psychiatrists, that psychiatrist from Portland, Oregon. So it's not really effective. Education, which we could do here today, right? I could just tell you, please don't discriminate against people with mental illness. They're just like you and me. Maybe you have a family member, maybe you have, you know, maybe you yourself, you know, that kind of thing. It helps, but it's not sustained. It's not a sustained effect on attitudes and behaviors towards people with mental illness. The only sure way that CareOregon and company determined that changes people's thoughts, their hearts, their attitudes and behaviors towards people with severe behavioral health problems is contact. Having direct face-to-face contact with a person who puts a human face on what it means to deal with behavioral health issues. And though they found too that there had to be what's called a high degree of disconfirmation of stereotype. Just means that the person makes you pause and say, oh wow, that could be me, or that could be my brother, that could be my cousin, that could be a colleague, right? So for that purpose, and with great gratitude, I want to introduce David Lee Greenlee, who will bring the personal perspective, the recovery, first-person perspective. Please give David a warm welcome for.
Thanks, everyone. So my name's David, and it is my honor to be here today. I was very excited when Paul and John gave me the opportunity to come do this. One of the very first things that I want to say is how grateful I am, because doing this benefits me just as much as it does you. So I'm going to kind of share my personal story with you as it pertains to depression and recovery.